Welcome to Face the State. I'm Ariana Bennett. Thank you for joining us. My subject for this show has been doing important work in our community for nearly 30 years. It started as a tiny center helping in the fight against HIV transmission. Now it's one of the larger healthcare providers in our area, and it's expanding to serve even more people with a new department of addiction medicine. So Dr. Faith Whittier and Dr. Taylor Tomlinson with Northern Nevada Hopes are here with me to talk about that. Thank you both so much for coming on the show.
Thank you for having me.
Thanks for having us.
Oh, it's my
Excited
pleasure.
to be here.
Yeah. Okay, so this is cool. What is the issue that prompted the need for a whole department of addiction medicine?
I think that's a really, really great question, and I'm so excited to be able to talk about our department. I think that first and foremost, what we're trying to do with creating a department of addiction medicine is really to bring awareness to addiction and substance use disorders being chronic diseases that have excellent treatments and really are associated with excellent outcomes for patients if they're interested in treatment. So what we're doing is trying to make our community aware of this treatment and accessible to all that need it.
I think it's really cool to hear you say that there's excellent treatment options out there, because it really wasn't that long ago that I think the prevailing wisdom, or at least the idea in the community, was that the best form of treatment is prevention, and once you are addicted, you know, there's just not a whole lot of paths forward. So that's no longer the feeling then.
No, I think specifically for opiate use disorder, alcohol use disorder, there are really evidence-based medications and forms of treatment that deliver outcomes that people really care about, patients really care about. I mean, decreased risk of overdose, decreased risk of death, decreased risk of hospitalization, use overall, decreased transmission of HIV and hepatitis C, and decreased return to jail. I mean, really, really important outcomes that people in our community care about. We have medications and treatment that deliver those outcomes. So really exciting to be able to offer that.
So then, is the need in our community so great that it necessitated a whole department, or was it this is just a different way of looking at the situation?
I think one of the things that we've been able to accomplish with the Department of Addiction Medicine under Dr. Tomlinson is really kind of reaching a broad population. In particular, we're now able to see subpopulations, maternity patients, and as well, in addition to the other populations that we serve. So I think being an FQHC and serving different adult populations, we felt that we would be the best ones to be able to bring this care.
Mm-hmm. And I think, you know, specifically in terms of how our community is being affected, I think, you know, in 2024, we were excited to see numbers coming down in terms of overdose deaths, but in the last quarter, we've seen those bump back up again. So it's really important that the community knows that there are treatment options available and that they have access to those treatment options.
So what are the factors that you've seen contributing to an increase then?
Yeah, I think our drug supply is really volatile. I think the majority of overdose deaths are really fueled by fentanyl, which is a high potency synthetic opiate, and increasingly so fueled with a combination of fentanyl with methamphetamine. And so those drugs in our community have really driven the overdose deaths that we have, and also driven the numbers of patients presenting to the ER needing help and treatment.
When we talk about the patients themselves, is there any commonality in kind of what got them started down this path, or is it a different story for each individual person? I guess what I'm curious about is, you know, how many of these are we seeing who started as, like, you know, they were taking it to manage post-surgical recovery, and then it got out of hand, or how many of them were exposed as children? Like, what are we seeing in terms of their stories?
Yeah, I'm really glad you asked that question, because I think it is a common fallacy that people associate addiction with moral failing. It's a chronic disease like the other chronic diseases that we treat in our clinic: diabetes, high blood pressure. It's not like somebody doesn't have enough strength or perseverance and that's why they're suffering from this disease. It's really rooted in neurobiology, in genetics, and sort of social, environmental, legal sort of environments that contribute to patients' experiences. However, you mentioned kind of pain pills being a root or a source of problems for people, and I think that as a physician, as a part of the medical community, we do understand that with pharmaceutical companies and industries pushing opiate medications for pain over the past 30, 40 years, that many patients did find their way to this path and this problem originally from prescriptions related to opiates for pain medicine.
And that's a pretty scary thing. I feel like it's a hard line to walk as a physician too, because you obviously don't want your patient suffering from pain, but how do you know when managing that pain kind of lapses into the next thing? Is there a way, or is this just, we hope that it doesn't?
Yeah. I think it's good stewardship
Yeah.
regarding prescriptions of opiates. We have a lot more data now than we did 40 years ago regarding how effective they are for pain, for both acute pain and chronic pain. And it's really practicing evidence-based medicine and having conversations with patients about their pain, how they're suffering around their pain, what their functional limitations are, and centering their goals and really, being as transparent as we can be about what medical information we have regarding the treatment of pain.
And the risk benefits and alternatives to pain medications, and really just having that relationship with your patient to understand when they're in trouble with pain medications.
Yeah, I mean, addiction is complicated and individual, I imagine, no matter the patient. But Dr. Whittier, you are specifically seeing patients now who are dealing with an extra complication, maternal patients who are pregnant and have dealt with addiction problems. What is that? How do you go about handling a situation like that?
Yeah, I think it's particularly difficult and challenging for patients that are pregnant. One of the things that pregnant patients were dealing with, a multitude of complications that they may have inherently in their pregnancy, whether that's hypertension, diabetes, social determinants of health. And then to put their addiction on top of that can be just an added complication. But I think just understanding the patient, really having that competent patient-physician relationship, I think really is the key to understanding our patient's needs and really building that trust in the relationship.
So what can you do for those patients who come to you who are dealing with addiction?
So one of the things that we do, and Dr. Tomlinson can talk a little bit more about that, is starting those patients when it's indicated on buprenorphine, which has been proven to be safe and effective in pregnancy. Obviously, making sure that we are dealing with not only their addiction, but with their any other complications that they may have related to pain. We certainly don't want to treat those patients any differently. They suffer pain in the same way that other patients would. So I think it's just understanding their addiction and how we treat those patients.
Okay, so there's a medication that pregnant patients can take that will help reduce the cravings for what they're addicted to and help them stay clean. Is that the idea throughout the pregnancy?
Well, I think, coming back for a moment, what Dr. Whittier has helped facilitate is creating a special dedicated program for women with addiction. And that's been a real gap in our community. Another example of a marginalized population that has difficulty accessing care just based on the nature of addiction and the stigma that exists around addiction. So creating a program at Hopes where patients can receive really wraparound care with case managers, nurses, peer support specialists, really providers dedicated to taking care of women during their pregnancy and taking care of them and their babies afterwards is really the first step in treatment. Prenatal care is really the first step in treatment. And then in regards to your question regarding medications, buprenorphine is one of the best medications to treat opiate use disorder. It is the standard of care for patients who have addiction to opiates, regardless of whether they're pregnant or not. And in terms of how we recommend that medication during pregnancy, the important thing for people to remember is it's very patient-centered. It depends on what their goals for the pregnancy are and whether medication kind of fits into that treatment plan. But yes, buprenorphine is very safe in reducing those outcomes we talked about, helping people reduce use, keeping them alive, safe from overdose, and really reducing the likelihood that they'll experience preterm labor or maleffects of using opiates during pregnancy.
Yeah, I think that's a great point. I think one of the things that we understood before starting this program is that we had a lot of moms out there that were suffering from addiction and they didn't have a place to go. We were really fortunate to receive a grant, a large grant from the state, and also several other supports so that we could start this program. So we wanted to provide a place where patients that had addiction could come to receive prenatal care. As Dr. Tomlinson said, a place that we would be able to address all of their needs. Behavioral health, case management, transportation, and that's in real time. I mean, we really sit down and understand the needs of each and every patient, understand what their limitations are, and I think that's how we've really been able to be really effective in this patient by being very patient-centered with each of the patients that we're seeing.
I'm imagining that there's probably a not small amount of shame involved in seeking care in addiction while pregnant. I don't know, maybe I'm completely wrong here, but what are you hearing from these patients?
I think stigma was one of the things that we were really, really concerned about, and in envisioning this program, we wanted to roll out this program with group classes. So these moms could come together, support each other on their journey through their prenatal care, through their addiction. And I think that's been really effective, these moms being able to kind of lean in on each other and us kind of being able to wrap around all the services that we have internally with HOPES, but we're also getting a lot of great support from the community and resources. So we're pretty excited about that.
Have you had quite a few takers?
Oh, yeah, into our program?
Yeah.
Oh, yeah. So one of the things that we inherently wanted to keep the program, it's a model of group classes, which is typically about 8 to 10 patients. That's a number that we really feel that in each of those groups that we can understand each mom on a very individual level and meet all the needs and resources that they have. And so we are somewhere around 50% there already, if not more. These moms have a lot of challenges, so some of them will come, some of them go, but that is what we're here for. We're here to understand that all the challenges that they have and keep connecting with them and keeping them connected to this program so that we can have the outcomes for mom and babies that we're looking for.
I imagine that you probably get a lot of relief, gratitude, lots of feelings from people who have been under this weight for a long time, both the pregnant patients and the not pregnant ones. What do you hear from the patients?
Yeah, I think one of the things that I think we hear is that these patients feel seen. They feel that they matter, that their care matters, and I think that's the most important thing. A lot of these patients have felt stigmatized. They've felt invisible in the community. They haven't wanted to seek care. So what we've tried to create is an environment where they feel very welcomed and non-judged.
Mm-hmm. I think that is one of the reasons that I continue on in medicine, is really getting to work with people who have experience with using drugs in that community. I see such resilience in that population of patients that inspires me every day and continues me on in this work. And I think one of the really cool things about HOPES is that we're expanding access to care. We get to do interviews with you, notifying our community about why substance use disorders exist in the world, how to treat them, and that makes clinical care more accessible for our patients. They feel more comfortable requesting treatment, talking about their history of disease, and that is very rewarding.
Yeah, they don't feel alone on this journey. That's the most important thing.
All right, well, that's a great opportunity for us to take a quick break, but sit tight. Coming up on Face the State, I'll be back with Dr. Whittier and Dr. Tomlinson to talk about some of the other issues facing healthcare right now. Stay with us.